Part 4 brings us to the most complex cases, when the immune system itself is the culprit, acting entirely independent of a current infection. This is the non-infectious inflammation group.
This group accounts for about 7% of acute myocarditis cases overall, but critically, it represents 15% of the high-risk, complicated cases.
So it's a small group, but a dangerous one.
Very much so. Our understanding of this comes partially from studying cardiac transplant rejection, which taught us several things about aggressive immune responses. That myocardial depression can be rapid and quickly reversible, that noncellular mediators like circulating antibodies and cytokines play a major role, and that prior injury, even a mild one, can expose hidden myocardial antigens, initiating a devastating autoimmune attack.
The most common diagnosis in this non-infectious category is sarcoidosis. Tell us about this disease profile and why it is so difficult to catch.
Cardiac sarcoidosis is the most commonly diagnosed non-infective inflammatory process affecting the myocardium. It's a systemic granulomatous disease.
What's a granuloma?
Think of a granuloma as a persistent cluster of immune cells trying to wall off a foreign invader or substance. Sarcoidosis affects the lungs most commonly, but also the skin, eyes, liver, and nervous system. The cause is understood as a combination of foreign antigen presentation, often environmental exposures like silica dust, mold, or pesticides, and a resulting dysregulated immune response.
And you mentioned a key diagnostic challenge. The heart can be involved without the lungs showing any disease at all.
That's the difficult part. Cardiac sarcoidosis frequently occurs without detectable lung disease, which forces the diagnosis to rely solely on cardiac clues. And its presentation is highly variable. Patients can have rapid onset heart failure, life-threatening ventricular tachyarrhythmias, severe conduction block, or simply minor findings discovered during an unrelated workup.
What's the key clinical clue that should immediately raise suspicion for sarcoidosis, particularly in the emergency room?
When heart failure or syncope is dominated by frequent or sustained ventricular tachycardia, or specifically an isolated unexplained conduction block, particularly right bundle branch block, and coronary artery disease, have been definitively ruled out, suspicion for sarcoidosis should be very, very high. This combination of electrical dysfunction and mechanical failure is uncommon in other cardiomyopathies.
And what are the challenges in diagnosis? It sounds like traditional pathology often fails here.
Imaging is absolutely key because the scattered granulomata, the hallmark of the disease, are commonly missed on a routine endomyocardial biopsy.
Because the inflammation is patchy.
It is. It's not diffuse. Therefore, we rely heavily on non-invasive imaging. We use PT scans, positron emission tomography, which can highlight active, metabolically glucose-avid lesions in the heart, showing us where the inflammation is currently focused. The MRI then shows us the resulting fibrosis pattern. The diagnosis often relies on finding biopsy-proven sarcoidosis in an outside organ, like a lung or skin biopsy, and combining that with the specific imaging clues in the heart.
How is it treated, given that the disease is the body attacking itself with these granulomas?
The primary treatment is aggressive immunosuppression. This is generally initiated with high-dose glucocorticoids, or steroids, often for many months. And because long-term steroid use has serious side effects, steroid-sparing agents like methotrexate or mycophenolate are often added early to allow the tapering of the steroids.
And what about the electrical problems?
Crucially, devices are very frequently indicated because of the high risk of tachyarrhythmias and conduction block. These devices must usually include both pacing capability for the block and defibrillation capability for the ventricular arrhythmias.
Next, let's look at the two most aggressive, rare, and often life-threatening forms of non-infectious inflammation, starting with giant cell myocarditis.
Giant cell myocarditis, or GCM, accounts for about 10–20% of biopsy-proven myocarditis cases. It is defined by its speed and its severity. It presents acutely with rapidly progressive heart failure and life-threatening tachyarrhythmias. It typically affects older individuals than acute viral myocarditis and is often associated with other systemic autoimmune disorders.
Is GCM easier to diagnose via biopsy than sarcoidosis?
It is, yes, because the inflammation is more diffuse and destructive. Pathologically, GCM involves widespread inflammation, often leading to a successful biopsy that shows these large, multinucleated giant cells surrounded by extensive inflammation, sometimes including eosinophils.
But the prognosis is poor.
It is. Because it presents so aggressively, many patients are already in cardiogenic shock. Most patients presenting in shock progress to need urgent mechanical support or even heart transplantation because the heart muscle is destroyed so quickly. Treatment requires immediate and intense combination immunosuppression, often similar to the protocols used for severe heart transplant rejection.
And the second rare, aggressive form, eosinophilic myocarditis.
Eosinophilic myocarditis is another cause of fulminant myocarditis. The key diagnostic clue here is hypereosinophilia, which just means a very high level of eosinophils, a specific type of white blood cell in the peripheral blood. This is present in about 3/4 of diagnosed cases.
And the eosinophils themselves are the problem.
The toxicity is caused directly by the granules released by the eosinophils, which are highly damaging to the heart muscle. This can lead to very acute injury, sometimes resulting in apical thrombi blood clots in the heart apex, and eventually subendocardial fibrosis in chronic cases.
What causes this flood of eosinophils?
The causes vary widely. Up to a third are due to hypersensitivity to chronic medications. This is important because it can often be cured simply by withdrawing the drug and giving a course of acute steroid therapy.
So it's reversible.
It can be. Chronic parasitic infection is another cause, particularly in certain global regions, and treated the parasite cures the myocarditis. Or could be underlying conditions like eosinophilic granulomatosis with polyangiitis EGPA or hypereosinophilic syndrome HES.
What happens if eosinophilic myocarditis is left untreated in the long term?
If left untreated, the initial inflammatory necrosis progresses to aggressive thrombosis and valve disease. The chronic state is defined by progressive endomyocardial fibrosis with restrictive physiology, meaning the heart becomes stiff and can't fill properly. This chronic state is historically known as low-floor endocarditis. It has a very poor prognosis if it's not caught and treated early.
This raises an important question. What happens when the treatment for one disease is what causes the inflammation? We're talking about iatrogenic inflammation, specifically related to powerful cancer drugs, which has become a major clinical concern in recent years.
This is the era of immune checkpoint inhibitor, or ICI myocarditis, and it is arguably the most challenging and dramatic form of non-infectious inflammation we are currently confronting. These drugs, monoclonal antibodies targeting things like CTLA4, PD-1, and PD-L1, are designed to effectively unblock the host immune response to achieve remarkable tumor remission.
They take the brakes off the immune system.
They take all the brakes off. But the unblocked immune system loses its specificity and can attack healthy tissue as collateral damage.
And the heart is one of those tissues.
Exactly. This process, while life-saving against advanced tumors, unleashes an immune attack against any host tissues that also express the same checkpoint proteins, including cardiac muscle, skeletal muscle, and the vascular lining. The resulting myocarditis can be fulminant, rapid, and often accompanied by myositis inflammation of the skeletal muscles.
Given the urgency in the high-risk population, what is the clinical action plan for this drug-induced toxicity?
The diagnosis must be suspected immediately in any patient receiving ICIs who presents with acute cardiac symptoms, elevated troponin, ECG changes, conduction blocks. Urgent admission to the coronary care unit is the absolute recommended first step.
And treatment has to be fast.
Crucially, treatment with high-dose glucocorticoids must be initiated rapidly, often along with other immunosuppressants. Initial fatality rates for ICI myocarditis were disturbingly high, around 30 to 50%, though outcomes are improving with earlier recognition and aggressive, immediate immunosuppression.
Before we move on, we have to address the rare but publicly discussed concern about vaccine-related myocarditis. What does the data actually tell us?
Myocarditis has been implicated rarely after certain vaccines. This was first studied decades ago after the smallpox vaccine in military populations, where it was generally assumed to be a hypersensitivity response.
And more recently?
More recently, of course, are the COVID-19 mRNA vaccines. The estimated overall rate is about 1 case per 100,000 vaccine doses, though this rate increases to 2 to 3 per 100,000 for recipients aged 18 to 39 years, particularly after the second dose.
And that highest risk demographic, young men under 40, is the same group at highest risk for primary infectious myocarditis following COVID-19 or other viruses.
Precisely. It's the same underlying demographic vulnerability. Crucially, the data shows that most cases of vaccine-induced myocarditis resolve quickly, often without hospitalization. And those who are hospitalized typically have mild transient disease.
But the risk changes with more doses.
The risk does slightly increase after repeat doses, necessitating a personalized benefit-risk assessment, especially for men in that highest risk category. But it's important to keep perspective. The risk of cardiac injury from the natural infection itself remains substantially higher and more severe.
Finally, in Part 5, let's turn to the progression from an acute event to the long-term reality of heart failure and how our understanding of causality is being overturned by genetics.
Right. Patients who present acutely with a reduced LVEF are definitely at higher risk of developing chronic cardiomyopathy. This is particularly true if their troponin level remains persistently elevated and the LVEF does not resolve in the initial months. We know that ongoing inflammation and developing fibrosis can be revealed by chronic cardiac MRI or biopsy.
For chronic nonspecific inflammation, that lingering lymphocytic type, are there any long-term anti-inflammatory treatments that actually work?
Unfortunately, no. For chronic nonspecific lymphocytic myocarditis, multiple trials attempting immunosuppression have not demonstrated convincing benefit. It seems that once the damage is chronic, suppressing the immune system just doesn't reverse the damage.
So it's too late.
It seems to be. There's also still so much uncertainty regarding the significance of persistent viral genome fragments and anti-cardiac antibodies found in chronic disease. They could be causing damage, or they could simply be neutral bystanders or relics of a past fight. We just don't know for sure.